It's always good to start out with a couple of introductory comments about colorectal cancer. We all know these figures, but it remains the second leading cause of cancer death in the US behind only lung cancer, the leading cause amongst non-smokers, and obviously that's a big problem, but the tragedy is it's almost entirely a preventable disease, or at least we feel that is the case. And the reason for that is because we can identify a benign precursor. This isn't like breast or lung cancer screening where we're looking for cancer. By and large, we're looking to prevent it by targeting what are advanced adenomas, and we'll get into that concept quite a bit throughout this talk. So that's the rationale for screening. It's a benign precursor. We're preventing more than screening. So what's the disconnect? The problem is most people are not screened at all or are being under-screened, that is, with a fecal occult blood test or some other test that doesn't have preventive advantages to it. It's simply looking for cancer or a bleeding cancer or so forth. Looking at it schematically, of course, benign polyps are quite common, as we'll talk about. We can see these in up to 50% of patients, adults over 50, have at least one tiny polyp. The trouble is, a very small fraction of them will gain enough genetic alterations, mutations, what have you. We won't go into detail on that, but at some point malignant transformation occurs. So there's a very broad window for prevention, that's the good news. Even early cancer detection, as we know, can be curative, so the window for cure is even broader. The problem is there's a vast sea of polyps, the vast majority of which will never become cancer. Even if you focus on adenomas, that's up to 20 or 30% of our population will have at least one tubular adenoma. That's not the target. As we drill down more and find these advanced adenomas and advanced neoplasia, if you include cancer, this is really the prime target. I'll spend some time going over what these are, and the good news is CTC is actually an ideal modality for detecting advanced neoplasia, and so that's the good news. I'll interchangeably use the term CTC and VC, so excuse me for that. I tend to use VC when I'm talking to clinicians and patients, and CTC more for the literature, although really CTC is the preferred term. And we all know what virtual colonoscopy is. It's nothing more really than a CT scan in which the patient has undergone some form of bowel preparation and distension, and then we use our 2D and 3D methods of detecting focal lesions. So the basic ingredients, and I'll take it from our perspective. From day one, we've used a cathartic approach with oral contrast agents. We use 2% or dilute barium and gastrograph. And this is the order we have them take it the evening before exam. And that is to remove the bulk stool and then tag what's left over. The secret of our prep is really gastrographing. That provides a second cathartic kick. It washes off all the residual stool, and you can therefore do a 3D evaluation, which I feel is very important if you're looking for polyps. We've switched over many years ago to automated CO2. It's more comfortable for patients. There's almost no post-procedural discomfort, and it's easier for technologists. There's an endpoint that's very much, you just let the machine do what it does, basically, compared to room air, where the endpoint is less clear and has some dangers. Almost all perforations in the literature have resulted with room air administration. Almost impossible to perforate a normal colon with this low-pressure CO2 device. And there's a lot of data now coming out, some of which was presented at RSNA, that shows the safety of this CO2 approach. So it's better in many ways, and I'm a believer in that now. Of course, we use multi-detector CT. Our original study used 4-detector row. We're using mostly 16 and 64 detector row, but this is very good use of an 8 or 16 detector row scanner. We certainly don't need anything more than that to scan this static bag of gas, if you will. I feel strongly, again, if we're looking for benign polyps, 3D will get you where you want to go very easily without the pain. This is the system we've always used. There are other systems, of course, but it's an issue of 2D and 3D interpretation, seamlessly going back and forth, knowing what you've seen. There's a lot of bells and whistles, and I won't have time to get into that. In the pitfall section, we'll go over some of those things. Now let's talk about previous studies. This gets back into the old 2D days, that is scrolling through the images like we read any other CT scan. This is not the way to read CTC by and large. I view the 2D images as the source data, much like CT angiography study, where you really want to confirm everything on the source data. That's the truth. The 3D views and all the other fancy views can easily show you potential abnormalities, but the source data is what provides the ultimate truth. However, you don't want to go looking through tens of thousands of 2D images for every large adenoma you might find. It's just too difficult. Well, it actually works if you look at a polyp-rich population. These were very early proof of concept studies that provided some encouragement. But when this 2D approach was applied to more of a low prevalence screening population, it really fell flat. It was detection of large adenomas 1 centimeter or greater was on the order of 50% or less in all of these studies. Now, in addition to being old in the VC timeline, these also were primary 2D and did not use oral contrast tagging. So those are two things that it's hard to really separate which is more important. I think they're equally valuable, both the 3D detection and the oral contrast. So I got involved when I was at the Bethesda Naval Hospital, the National Naval Medical Center, involved in this DoD multi-center trial. What did we do a little bit differently? Well, as I mentioned, we used 3D polyp detection. That system was fairly robust even back in 2001. And we also used the oral contrast agent. So those were two things that at the time were felt to not be necessary. So our results, and this is old data, but this is what we found back in that trial. At the 8 millimeter threshold was really our sweet spot. You can see sensitivity for adenomas at that point was actually higher than optical colonoscopy. A little, very comparable, but slightly less when you get down to the 6 millimeter threshold. And this is where specificity really plummeted. As I mentioned, very old data. Our numbers for positive predictive value now down to 6 millimeters is equal to that of 10 millimeters. So at that point in time, 2002, 2003, we were good for 8 millimeter lesions. Now we're just as good down to 6 millimeters, and that just goes for all the improvements in prep, distension, scanning, software, and so forth. So at this point, though, we felt for clinically relevant polyps, certainly for advanced adenomas and advanced neoplasia, we were as good, if not slightly better than optical colonoscopy. And you might ask, how do we know that we're better than the actual reference standard? Well, it's that segmental unblinding process where we don't reveal our findings until they've evaluated that segment at subsequent colonoscopy. They had to go back and find their own misses, and you can imagine that there's a lot of pride on the line there. So the fact that we did uncover more misses by them that way than our primary CTC approach, I think is pretty good data that CTC can detect these larger lesions. There are many other ongoing or published trials, such as the Akron trial, many throughout Europe, some of which will be coming out soon. Hopefully, the CIGAR trial was a randomized control trial that shows CTC was equivalent to colonoscopy for cancer detection and for large polyps as well. That should be coming out in the near future. I won't go into detail on this just for time constraints. But I would like to focus on the guidelines for a minute here. American Cancer Society guidelines were revised in 2008, and for the first time, the American College of Radiology was at the table. Previously, it had just been the consortium of the GI groups, the ACG, ASGE, AGA, and the American Cancer Society. Well, now the ACR got involved. There's a few radiologists sprinkled in here, Beth McFarland. I was involved in this as well. And a lot of gastroenterologists. But what did these guidelines do? I thought this was a nice step forward, I think, in colorectal cancer screening. For the first time, we're separating tests that are preventive versus those that simply detect cancer. So if you look at fecal occult blood testing, that may be an appropriate choice, maybe for a symptomatic 80-year-old patient. You're not really interested in this benign 6 millimeter polyp. You just want to know, is there cancer? But in the 50-year-old patient, these guidelines strongly emphasized prevention, and CTC made that list for the first time. And I'll mention barium enema, which made the list for the last time. So I can guarantee when these are revised, the thought is barium enema will probably drop off, but we didn't want that to happen until CTC was established. So that does give us a foothold still. And I think radiology is back in the game if we can establish screening, and it works very well, as I'll try to show you throughout this talk. Now, the progress beyond then, unfortunately, was kind of mixed. We thought we had made it at that point. The American Cancer Society gave it, its highest blessing. But then the U.S. Preventive Services Task Force came out after that with an insufficient evidence statement, I statement. And then, as you can imagine, like the mammography guidelines, I think some of us feel this was bungled a little bit. I don't think it was a fair review of the existing data. And enough said there, but unfortunately CMS looks more closely to U.S. Preventive Services Task Force than they do to the American Cancer Society and so forth. So they left CTC screening uncovered in their national coverage determination, despite the fact that the largest GI society, the American Cancer Society, and of course radiology, strongly supported coverage for Medicare beneficiaries. There have been some positives since then. The Blue Cross Blue Shield tech assessment, if you will, showed that it met the criteria for a screening test. There are 20 states that quote, mandate coverage according to the ACS guidelines, but I'll be honest, I've never seen this challenged in any way. I've asked people from those states, if they've ever challenged this, and to my knowledge, no one has ever really put that to the test. So I don't think that's really gotten us over the hump. We did get Category 1 CPT codes as of 2010, so that's another big step in the process here. And then President Bush was screened when I was at Bethesda by colonoscopy, and that was a little disappointing because we had the trial underway. We were doing lots of VIPs. I won't go into names, but once it becomes public, I can talk about it. But Bush's colonoscopy was quite public. He had to hand the reins over to Cheney, if you can imagine that now retrospectively. Now, President Obama, he decided, his physicians decided, let's screen by CTC. We don't have to, give up power for that period of time we're under sedation. He had a negative exam, which was great, a very low-dose study. He's a thin guy. And it was done by the tech that I hired for that trial way back in 2001. So it's gratifying to see that it's doing some good. Of course, at that time, if you also recall, that's when all the medical radiation issues were exploding, the CT exposures and so forth. And even though that in the bigger picture, that's not at all an issue for CTC screening and also overblown in general, I wish we had time to get into that here, but we don't. But in any case, I feel like CTC is a little bit like my youngest son, George, here, who just turned 2. He represents CTC. We have reimbursement up here, and we'll eventually make this shot, but to date, it's been I gotta applaud him for trying here, but he's not gonna make it yet. We've worked actively on this. We're working, there's actually legislation in Congress. We're going to retry going through the USPSTF and CMS. And I think within a year or two, we should have coverage, but should doesn't mean anything to you if you have to make decisions based on your practice here and now. So it'll happen under the cover of darkness some night, and they'll just be like, oh yeah, we'll cover that. We don't know when exactly that's going to happen. So let's step back now. That was a look at the bigger picture here. We know this is a preventable disease. Stool-based tests are not preventive enough. They can be if you have a false positive fecal occult blood test that leads to a screening colonoscopy, then you did get screened, but that's a little more ad hoc. So I think we don't want to focus on universal polypectomy. It's too expensive, invasive. It doesn't really focus on what really matters. I think the goal is really to try to find large polyps and cancers in the majority, and then leave smaller polyps as a secondary issue, as we'll talk about. And it works out that CTC is ideal for this task. It doesn't require additional bowel prep. You can do same-day polypectomy. And colonoscopy is simply too expensive and too much of a limited resource to try to screen people. And if everyone woke up tomorrow, 50 and older, and said, I want that screening colonoscopy that I'm, if you're lucky enough to have coverage at least, if they all woke up and decided they want it, obviously we wouldn't be able to provide that service. So let's talk about the advanced adenoma. I keep hinting about this. This is the optimal target for colorectal screening. That's true from both clinical and cost effectiveness perspectives. It's defined as a large adenoma, 10 millimeters or greater, or one that harbors a prominent villus component or high-grade dysplasia. Now the good news is, in our experience, the vast majority of these are large. So regardless of the histology, size alone can be a very effective surrogate. And again, that bodes well for a test like CTC, which is a size-based test. We can't obviously sample histology. Many of these are proximal to the splenic flexure, so that's why we feel total colonic examination in the US is the way to go. Flexible sigmoidoscopy can certainly reduce colorectal cancer mortality, but it obviously will not address the right-sided lesions, at least those that are in isolation, which of course happens. CTC has been shown to be comparable, if not slightly better than colonoscopy for detecting these, so it's really in our wheelhouse. If we look at examples, the reason is these are almost all large, lobulated, whether they're pedunculated, flat, what have you. They're all quite easy with reasonably good prep and distension. These are obvious tumors to find. And going back to our schematic here, colonoscopy operates on this end of the spectrum, really trying to focus on universal polypectomy, remove everything, even though maybe 1 in 1,000 of these will ever become cancer, maybe less. Fecal occult blood testing, which is done throughout the world, unfortunately addresses the issue long after the cows are out of the barn, I guess, as we say. And the real sweet spot, I think, luckily, is where CTC operates. We're looking for large polyps. Of course, we don't want to miss the early cancers. They're quite obvious, as I'll show you. And that's really the goal. So our second phase, this is now at the University of Wisconsin. This is our second study that we published in the New England Journal, and this focused on advanced neoplasia. Now this is a different trial design. This is parallel screening. So these are screening studies performed in our general population, patients were either screened by CTC or colonoscopy, and you can see very, very nicely age-matched. This wasn't randomized, so we can't call it a randomized control trial, but you can see there are very well-matched asymptomatic screening populations. We sent about 8%, that's still about our number, 8% go to colonoscopy from CTC, so less than 1 in 10. And our goal is really advanced neoplasia, and you can see we equaled the yield of actual removal of advanced neoplasia quite nicely, and even had a lot more cancers, which we're obviously doing a follow-up of this. We know some of the cancers that were missed in this study have surfaced, but we think that'll probably even out as we do patient follow-up. Right-sided cancers are quite frequently missed at colonoscopy. That's kind of the dirty secret. The number of polypectomies, and this gets to cost effectiveness and complication rates and so forth, to arrive at the same end goal, we have to do many fewer polypectomies, and if you exclude the diminutives that they find along the way, it's actually under 400, so it's a very nice ratio as opposed to thousands of polyps to remove just to get to the same endpoint of advanced adenomas. They had 7 perforations in this arm. We didn't have any, and we have yet to have a significant complication of any kind now that we're up to about 9,000 patients at our center. So what about cancer detection? This is not the main issue, but of course we don't want to miss a cancer. That's pretty obvious. We only see 1 in every 500 patients screened. We did a meta-analysis that we published earlier this year, I guess, and going back all the way to the early days of CTC. So any 2D, lack of oral contrast tagging study, we included all of those. And even at that point, because it's not a 3D issue, we can find cancers pretty easily using any technique as long as they're prepped and distended in some way. This compares favorably to colonoscopy in these same trials, ones that use segmental unblinding. And then there have been other data out recently published that show that right-sided cancers are possibly being missed. We know that a large study out of Canada showed a mortality benefit for left-sided cancer, but there was nothing for the right side. So are they missing them? Is there a different tumor histology? It's something we debate about, but I think part of the issue is CTC very easily evaluates the right colon. It's the easiest thing to distend. The physical distance from the anus obviously isn't the issue because it's a virtual exam, so to speak. Here's one of the cases from that trial I showed you earlier. This was obviously one of the perforations, as I hope we can all appreciate. This patient went to immediate sigmoid resection, and about 1.5 years later came back with fecal occult positive tests now, had turned positive. The clinician, referring clinician, did talk the patient into a CTC. They didn't even want to do that, not surprisingly. And this is an old study, and it's got a 90-degree field of view, so it feels a little narrow. But there's a pretty obvious semi-annular lesion. This was asymptomatic other than the positive FOBT. And of course, we always confirm this on 2D. Here's what it looks like on soft tissue windows. There was a second mass in the more proximal transverse colon. And these were synchronous cancers that were almost certainly present at the time of that colonoscopy, which unfortunately only got to the sigmoid colon because of the perforation. What about cost effectiveness? I could give a whole lecture on this, and you'd have to have a lot of coffee on board to sustain that, but let me just bottom line it in one slide here. One of the studies we looked at, and these are all done with a gastroenterologist from Rome, who I think has a very good model for these studies. And you can see if we sent every tiny diminutive lesion to colonoscopy from CTC, it would take, theoretically that is, take it with a grain of salt, thousands would need to be sent for every cancer prevented at a cost of almost $500,000 per life year gain. So just to have someone gain 1 extra year of life. Whereas if we just sent the large lesions, it would only take about a dozen or so before we theoretically, again, prevented a cancer. And it would actually be a cost savings measure because colorectal cancer treatment is becoming so expensive, and we didn't even include what the real costs are. It costs over $200,000 for a chemotherapy regimen at our center. And of course, we use just Medicare numbers, so the treatment assumptions are not nearly that. But it certainly can be, I think, cost savings if we simply screened everyone with CTC, sent the large polyps, forgot about it, anything less than that. And we'd be doing clinically the right thing in addition to economically. But that will probably never happen. But in a perfect world, that's how. If I were king for a day, another study. This was probably a more important trial we published in Cancer, a more classic cost-effectiveness analysis. And we actually were for the first time we assumed, okay, we're not calling diminutive lesions, so let's not assume in our model that every tiny polyp detected at CTC goes to colonoscopy, because you're obviously stacking the deck. So this was more, I think, of a fair study, and the cost per life year gained was less than FlexSig and colonoscopy. Of course, because a radiologist was the first author, I think everyone ignores this, but again, it's a GI model that we're using. We recently, actually I just found out this morning as I was checking my email that this is accepted to AJR, but this was a multi-center study. There were 3 centers it's doing a fair amount of screening. We sent out and got back over 1,400 responses. I won't go into details here, but this is why patients choose CTC. Not surprisingly, non-invasiveness, avoidance of sedation. You can drive yourself home, avoid risks. You can find extracolonic findings. I think that's an important issue that we'll talk about later. And actually, a third of people wanted to return to work immediately, so you can see how motivated our populations are. This was also from that same study, and you can see over 90% of patients, this is soft data, right? They're just survey data, but over 90% of folks felt their experience with CTC screening was excellent or good, and that's pretty impressive. I don't know why people are having so much fun exactly. I mean, I'd be happy with good, but I'll take excellent. I just don't know what we're doing. We don't give lollipops or anything. This is actually interesting as well. For those that happen to have both tests, whether or not they were sent to colonoscopy or they had a colonoscopy maybe 10 years, 5 years or earlier, of those that had both tests, 77% preferred the CTC test, only you can see less than 14% preferred optical, about 10% had no preference. And this is despite the fact that we don't use any sedation, and these people are heavily sedated. We give, on average, 7 or 8 milligrams of Versed, 200 micrograms of fentanyl at colonoscopy. So these people are by design sleeping basically through that study. Yet they still preferred, and it's mostly a recovery issue, I think. They're using room air. Patients are gassy all day long, and they don't feel so good for the rest of the day. We've already covered this, but advantages of CTC relative to colonoscopy, it's just as good for advanced neoplasia. It's not just our trial data, but other studies have found this as well, that it equals colonoscopy, if not slightly better for advanced neoplasia. It's clearly less invasive. We don't need an IV. We don't use any spasmolytics. In the US, we don't have any good spasmolytics that are FDA approved, and I don't think it's necessary in most cases. The extracolonic evaluation I'll talk about later. I've talked about cost effectiveness. And also, let's just keep in mind, we're not throwing away colonoscopy. We're adding CTC, so the additive adherence will obviously have a complementary effect. Now, what are the drawbacks? There's a bowel prep that's required. However, this allows us, since we do a cathartic bowel prep, and it's actually low volume and much easier to tolerate than the 4-liter or 2-liter PEG preps, it allows for same-day polypectomy, and the preps are quite good because that gastrographin, again, is the key. It's non-therapeutic, so it actually works well in people that have a less than 5% chance, if you're 50 and older, of having a large polyp, just in the general population. 1 in 20 chance of needing that polypectomy, basically. So it's pretty good to focus a non-therapeutic approach to something that is only a 1 in 20 likelihood. We don't mention isolated diminutive polyps, flat lesions, I'll mention real quickly. Radiation we won't have time to get into, but I will talk about extracolonic evaluation in a separate talk. If we look at these, I think, in a systematic fashion, I don't think these are truly drawbacks, but it does take some thought. I'll spend a couple minutes talking about these. The sub-centimeter polyp is clearly not what we're looking for. Even the 6 to 9 millimeter polyps, these are often basically pseudo-disease because they're not what we're screening for and trying to prevent, that is cancer. They're histologically very benign. And so diminutive lesions clearly are of no clinical significance. You simply can't go after. If this were a clinical issue, CTC would be dead in the water. But clearly, these are not worth going after. It's like removing everyone's mole in the room. It obviously doesn't make sense. Small lesions, some people call them medium size. I prefer to call them small. We can't completely blow them off. They're very histologically benign, but they're not negligible. So this is what we spend 90% of our time arguing over. What do we do with these intermediate or small polyps? I can say only about 4% of them have a villus component. They're almost always tubulovillus and very benign. They will grow if they matter. They will grow beyond 1 centimeter well before turning into cancer in almost every case. And they almost never have high-grade dysplasia or cancer. I think the old data, we have to sort of relearn. This is a paper we published last year in a GI journal. We've looked at, and this is similar to other screening populations, the old data was, about 10% of 1 to 2 centimeter polyps are cancer. That was sort of what we always learned in residency from some of my venerable mentors. Now if you look at screening populations, asymptomatic screening populations, less than 1% of 1 to 2 centimeter polyps are cancerous. And that, this is our own data, but I can show you many other studies that are showing the same thing. So population, it's important to keep in mind, is this a general screening population? This includes family history. I'm not talking about family history, but these are asymptomatic individuals. Almost never cancerous below a centimeter. Here's an example of a screening colonoscopy done at our center. This is a 2 to 3 millimeter polyp. It turned out to be a non-neoplastic mucosal tag, whatever you want to call it. It has no threat of ever becoming cancer. Even if it were a tubular adenoma, it would be meaningless. So at CTC, we of course, this would have been a normal exam. Even if we saw this definitively, we would not call it. I'll talk about that a little bit later, how we handle those. But this patient came back a couple of days later feeling dizzy, not doing well, and you can see has a ruptured spleen and hemoperitoneum, required an emergent splenectomy. And that was actually maybe not due to the polypectomy, but the trauma, probably the tension on the phrenicocholic ligament or something. Anyway, we just wrote this up. This just came out. We've seen 11 cases of this it wasn't all at UW, but we've seen this enough that if you see supposedly non-traumatic splenic rupture, one question you might consider is, has the patient had a colonoscopy? It could be as long as 2 or 3 days after the colonoscopy that they actually present symptomatic with that when it finally ruptures. Small polyps, we have to think, there's a different way of approaching things. So we want to find the big polyps, and that immediately lowers your risk profile to where you're extremely low risk. So at that point, we don't want to do anything expensive or invasive. And so if we do have an isolated small polyp, the one way to look at it is the likelihood of that, say, 7 millimeter polyp to become cancer and affect your ultimate survival is much less than the risk of a perforation to remove that polyp. So that's one way to look at it. And again, we do this with other things. Pulmonary nodules, we're now taking a more rational approach and so forth. Flat lesions, I don't want to spend a lot of time on flat lesions, but just to say they are not nearly as important as it was overblown to be. They're actually much less common than polypoid lesions. They're almost never truly flat. They're more superficially elevated, so the paper that caused all the fuss actually didn't have any of these, and they didn't have any of these. Rarely you can see a depressed lesion, but they all have a raised edge, and this bodes well for CTC. We can actually find these lesions. We're doing about as well as colonoscopy, and we've published quite a bit of data on that. So it's a very much overblown problem. The one flat lesion I do pay attention to is a so-called carpet lesion or laterally spreading tumor. These are 3 centimeters or greater. They usually look like a disrupted fold pattern. It usually has sort of rolled up or heaped edges, a little shouldering. And they're just a fixed lesion, and they almost always have contrast coating. The barium clings to these. The iodine may as well. But these are only seen, in my experience, with very few exceptions, seen in the rectum and the cecum. So here's a raised plaque lesion, again, as contrast coating, kind of subtle on the 3D, although if you have a good study, there's no doubt there's some distortion going on here. Fairly subtle at colonoscopy. This was an 8 centimeter villus adenoma. But just to show, these are still benign. This is a tubular villus adenoma. If you have a polypoid or mass-like tumor of this size, they're almost always malignant. So even in this case, these are more benign. But that's what we focus on. We don't want to miss those. I'll talk about extracolonic findings later. Just to recap this, because it may be important from a question sort of approach. We can generally reassure patients or adults that they have nothing wrong, about 90%. We will work up an extracolonic finding in about 5 or 6%. Many of these turn out to be relevant, about half of them. We do find extracolonic malignancy, 1 in 300. We find actual colon cancer, 1 in 500. So we see more cancers outside of the colon. And there's lots of other screening opportunities that I'll talk about later. And I think that it's coming back to half body or whole body screening. But if we approach it, I think, a little more rationally, I think the glass is actually more than half full. And it's really it was handled poorly the first time through, but I think we can address this screening issue. We have the information, why not use it? Just real quickly on our screening program. So we've been doing this. We published that paper in '03, late '03. I actually joined UW right during the same month, met with our medical directors shortly thereafter, and was able to get screening coverage just for our center. So we've been doing screening since then. We haven't done a lot. We're closing in on 10,000 screening cases. That's a small fraction of what we should be doing, but we're still not there yet because a lot of primary care providers, look at the bigger picture. It's not yet an accepted test according to U.S. Preventive Services Task Force and so forth. We do these very early in the morning to allow for same-day polypectomy. Right now it's just one of us. 6 of us are reading these, so I read these less than once a week. And I've polled all of us, and it's our favorite practice. It's our favorite service to rotate through. It's very different. We sequester ourselves. We only read the CTC studies, have the music going, of course, so it's actually pretty enjoyable. It actually hasn't negatively affected GI. It's given them more truly therapeutic procedures, and their overall volume has increased above and beyond what we send. There's sort of a synergistic effect. Our colonoscopy referral rate, again, 5% for large lesions, but then we do offer same-day colonoscopy for small polyps if the patient wants to. Most of these are performed with a single prep, so it's very patient-friendly. But the vast majority of patients who undergo CTC screening avoid any invasive procedure beyond just the minimally invasiveness of CTC. Our positive predictive value, we've published on this, it's much higher, well over 90%. That's much better. We didn't really know what we were doing back then. We had a lot of false positives. The Akron trial has very disturbingly low positive predictive value, so I won't go into that. But I think if you use a good prep, good distension, and so forth, this is pretty easy to get up there and have a high positive predictive value, or concordance, if you will, with colonoscopy. We've had no complications, as I mentioned. So in summary, this is a very powerful screening tool. It's accurate, safe, convenient, cost-effective, perfect for asymptomatic screening adults. It's synergistic with colonoscopy. I think in my opinion, it's a better test, but we're certainly not looking to replace it. We're just trying to add to it. The extra colonic evaluation, I think, is a net benefit. And this is perfect for advanced neoplasia, which is both clinically and economically the thing to shoot for. So we can clearly put a dent in colorectal cancer screening if this were to take off as a screening study.